I'm so pleased to welcome everyone to our forum webinar today. My name is Colleen Berry, and it is my great pleasure to co-chair the National Academies Forum on Mental Health and Substance Use Disorders together with Howard Goldman. Before we begin our formal program, I want to take just a brief pause to acknowledge the dual public health crises we are confronting as a society at this moment, both with profound implications for mental health and well-being. As we all know, the toll of the COVID-19 pandemic has had rapid and devastating effects on our health and our economy. And with the bleak milestone of 100,000 deaths last week and over 40 million lost jobs and counting. Together with one of our webinar panel speakers, Beth McGinty, who you will hear from in a moment, our Johns Hopkins team has a study coming out today in JAMA quantifying the huge increase in psychological distress since the COVID pandemic hit based on the Kessler-6 measure of psychological distress. These increases have been particularly large for young adults and within low-income and Latino populations. And we all understand, I think, that the COVID pandemic has the potential to make many other health challenges, like the drug epidemic, much worse without decisive action. At the same time, we are all grappling with the brutal, senseless murder of George Floyd, and it is clear that persistent racism and income and health inequities are themselves public health crises with profound implications for mental health and part of the fundamental work of our forum. As we dive into a discussion of how to improve care for mental illness and addiction, we can all be motivated, I hope, by the fact that the crises surrounding us today make the topics we're discussing all the more pressing and important. I want to move quickly to our session, but let me first thank the sponsors of our forum who are listed on the slide right here. Without the support of our sponsors, none of this work would be possible. The mission of our forum is to provide a structured environment and neutral venue to discuss data, politics, practice, and systems that affect the diagnosis and provision of care for mental health and substance use disorders. Our statement of task and other information about our forum can be found on our website, which you can see on the link right here. Please note that a recording of this webinar and the meeting materials will be available on our event webpage. I'm pleased now to turn it over to my co-chair, Howard Goldman, to introduce our planning committee co-chairs and to thank them and to acknowledge the entire planning committee for putting together this webinar today.
Thank you, Colleen. I have a logistical note before I get into the introductions, and that is to indicate that we are hoping to have time for participants in the webinar to ask questions after the panelists ask their questions. If you wish to ask a question, I direct your attention to the toolbar at the bottom of your screen where it says Q&A. That would be a place to click on and ask your questions. We'll curate all the questions and try to find one or two that might amplify the questions that our panelists will ask. I particularly want to thank Colleen for her introductory comments and align myself with those on the pandemic, on disparities, and racial injustice. At this point in the program, it's customary for me to say that it is my privilege to thank the Planning Committee. I want to say it is indeed a privilege to do that, as it has been a privilege to participate in a webinar, a privilege to work remotely, a privilege to avoid infection and to isolate from economic and racial injustice. We all need to acknowledge our privileges at this particular time in our history. I wanted to show you the names of the members of the Planning Committee. Behind this particular webinar and those that will follow is a team that met many, many times to consider what issues to address on integration, how to proceed. We worked very hard and set up what was intended as an in-person meeting. And instead, we responded and accommodated to the changes and the need to move this to a webinar format. I particularly want to thank the forum staff, Lori Gregg, Caitlin Friedman, and Anicia Wilkes for their flexibility and for organizing this. It's much more difficult to organize a webinar like this than in our original format. And we regret that it may limit our ability to interact back and forth. I want to acknowledge particularly the contributions of the co-chairs, who you'll hear from in a moment, Deidre Roach and Ruth Shim. Deidre Roach is a medical project officer at the National Institute on Alcohol Abuse and Alcoholism in the Division of Treatment and Recovery Research. And Ruth Shim is the Luke and Grace Kim professor in cultural psychiatry at University of California, Davis. In spite of all of our planning, I don't know to whom I'm throwing this over, whether it's Deidre or Ruth who goes first. So
it's actually me, and thank you, Howard, for those words. The Planning Committee has been hard at work over the past 6 months developing and organizing these workshop sessions. And we were originally planning this full day public in-person workshop for today. But we've all learned in this crisis how to pivot, and due to restrictions and travel, we're now operating with this series of webinars. So today we are beginning with our kickoff date as the webinar series. We will have additional webinars scheduled on July 29th, as well as August 26th. The webinars will examine approaches to facilitate the delivery of essential components of care for people with mental health and substance use disorders in primary care settings, using 3 illustrative conditions: depression, alcohol use disorder, and opioid use disorder as a framework. The first webinar will explore the landscape of evolving models of care, such as accountable care organizations, patient-centered medical homes, collaborative care arrangements, and how essential components of care for mental health and substance use disorders might be induced for those care models. The webinar will also explore the policy issues related to implementing these models as the essential components of care. The second webinar will highlight the essential components of care for depression, alcohol use disorders, and opioid use disorders in primary care settings, and we'll also discuss the key factors that support or impede implementation of these essential components. And the third webinar will explore improving the workforce to support the provision of the essential components of care, and we'll also focus on addressing financing, payment, practice, and systems level issues, policies, and incentives to support provision of essential components of care. Proceedings from the webinar series will be published from the workshop discussions, including the audience question and answer sections. And now I will turn it over to Dr. Roach.
Good morning, everyone. Our first webinar will feature 2 speakers, Drs. Gail Dowmett and Beth McGinty. Dr. Dowmett is the Samsung Professor of Medicine in the Division of General Internal Medicine at the Johns Hopkins University School of Medicine and is Vice Chair for Clinical and Translational Research in the Department of Medicine. Dr. McGinty is the Deputy Director of the Center for Mental Health and Addiction Policy Research at Johns Hopkins and the Associate Director of the Alacrity Center for Health and Longevity in Mental Illness. Welcome, Dr. Dowmett.
Hi, good afternoon. I want to say it's an honor and a privilege to be participating in this forum. I'd like to thank the entire planning committee for having us, and thank you for the meaningful introductory remarks by Colleen, Howard, Deidre, and Ruth. So let's first frame the problem. Please, you can go. Advance. Mental illness and substance use disorder, also known as behavioral health conditions, are significantly undertreated in the US. In fact, although about 20% or 1 in 5 US adults experience mental illness every year, in 2018, only 43% of adults with mental illness received any mental health treatment, and only 11% with substance use disorder received addiction treatment. We know that mental illnesses and substance use disorders are highly comorbid with one another and with common physical health conditions. Mental illnesses are common in the millions of Americans with cardiovascular disease and diabetes, for example, and substance use disorders are also comorbid with a range of medical conditions, including HIV and chronic liver disease. We also know that people with medical conditions such as cardiovascular disease or diabetes who have depression and whose depression is untreated have poorer health outcomes than those without depression. And despite high comorbidity, physical illnesses are frequently undertreated among people with behavioral health conditions. So this suboptimal care for people with behavioral health conditions has major public health implications. Depression is a leading cause of disability in the US and worldwide, and people with serious mental illnesses, such as schizophrenia, bipolar disorder, and major depressive disorder, die at least 10 years prematurely relative to the overall population, mostly due to cardiovascular disease and other medical conditions. More than 200,000 people died from overdose deaths from opioid use in the past 20 years. Despite the high burden of behavioral health conditions and their comorbidities, the US specialty mental health and addiction treatment systems have historically operated outside of the general medical health system. And this fragmentation, as we know, is an important driver of undertreatment. Development and implementation models for integrating general medical and behavioral health care, as we call integrated care, have been a priority in the clinical and health policy communities for decades. So progress has been made. The majority of mental health services are now delivered in primary care settings, but these integrated care models that have been shown to be effective in clinical trials have not been widely implemented outside of demonstration programs or other time-limited mechanisms. So we have really unrealized opportunities to address mental illness and substance use disorders in primary care settings. Please advance. I'm now going to describe primary care integration models for integrating behavioral health services into primary care and other general medical settings. The majority of integrated care interventions shown in clinical trials to improve treatment delivery and patient outcomes implement variations of the collaborative care model. Collaborative care is based on Wagner's chronic care model. The chronic care model has been shown to improve chronic illness care through use of a team-based, proactive, and population-based approach to identifying and treating chronic disease. The chronic care model displayed here defines essential elements of health systems that encourage high-quality chronic disease care. Wagner and his team understood that improving care for persons with chronic illness would be hard with usual episodic visits with primary care physicians, and that really a team approach was needed. The model includes elements of community resources and policies, and then within the health system, self-management support, delivery system design, decision support, and clinical information systems. These elements facilitate productive interactions between activated patients and a proactive clinical team to improve health outcomes. The collaborative care model was developed by a group of researchers at Group Health in the University of Washington, led by Wayne Caton, to focus on improving care for depression in primary care. In collaborative care, primary care physicians work with a care manager and a consulting psychiatrist to proactively identify, treat, and monitor people with behavioral health conditions. So both the chronic care model and the collaborative care model have three core tenets: population-based care, measurement-based care, and stepped care. In contrast to clinicians who see one patient after another individually and focus on the patient in front of them only, population-based care emphasizes improving quality and outcomes on defined populations with chronic illness. In order to have population-based care, we need a registry to identify those that have the behavioral health condition. What's needed for measurement-based care is you need a clinical measure for primary care practices to diagnose and then monitor progress of treatment. So, for example, for depression, the PHQ-9 could be a recommended tool. The PHQ-9 or other measures then need to be tracked to identify patients who may not be improving. And then a stepped care approach is applied systematically to enhance the treatment for patients who are not meeting the targets. For example, if the PHQ-9 is still high after initial treatment, if patients are taking the medication could be increased. This is very important because lack of intensification of treatment is very common in patients with depression in primary care. So what is the evidence that collaborative care works? A large and conclusive body of evidence for randomized controlled trials supports the beneficial effects of collaborative care for depression care, both access, quality, and patient outcomes. And also there's evidence for this model for anxiety and comorbid physical health conditions, and even evidence suggesting that collaborative care could improve outcomes for people with bipolar disorder, schizophrenia, alcohol use disorder, or opioid use disorder. You can advance. However, as I described it, the collaborative care model implemented as it's supposed to be is complex with different components needed, including multi-specialty members of the healthcare team. There are other simpler models of integrated care. What are these models and how well do they work? Two simpler models are screening, brief intervention, and referral to treatment, or SBIRT, and consultation liaison models. Let's start with SBIRT. This has been predominantly used for alcohol and other substance use problems. It uses validated screening measures to identify patients and then stratify them by level of risk. Patients that are low risk might receive brief behavioral therapy for substance use and or a motivational enhancement intervention designed to help them to change their behavior. And high-risk patients would also receive referral to specialty treatment. To date, this model has mostly been tested in primary care and emergency department settings. And there's a limited body of research that has mixed results. One high-quality trial found no effects of SBIRT on alcohol or substance use at a 6-month follow-up. However, a recent systematic review did find that brief interventions delivered in primary care or emergency department settings can reduce alcohol consumption and improve alcohol consumption behaviors. The second type of model is consultation liaison models. These are broadly defined as models where a process exists for general providers to consult behavioral health specialists. And some studies do suggest that these can improve depression outcomes and reduce length of general medical inpatient stays among those with mental illness. But we need more data on these kinds of integrated care models to know how they really work. Let's move to the next slide, and I'm going to talk about the key elements of integrated care. As we've said, general medical settings can implement a wide range.
It appears that Gail Daumet's presentation is frozen. I don't know whether Beth McGinty can pick up.
Great. Hi there. So I'm happy to pick up, and if Gail is able to unfreeze, I'll let her take it back over. So she was just about to dive into this slide on key elements of integrated care. You see this is labeled panel A. On the next slide, we'll have a panel B because we've organized these key elements into two buckets: process of care elements shown here, and then as a preview of the next slide, structural elements. So these process of care elements include proactive and systematic patient identification and connection to evidence-based treatment. This proactive approach is a hallmark of Wagner's chronic care model, and in direct contrast to historic MO of medical practice, where we are simply responding to patient needs as they appear in our offices. Team-based care by a multidisciplinary team of general medical and specialty behavioral health providers, including a behavioral health care manager and a consulting psychiatrist in the collaborative care model. Information tracking and exchange among providers, systematic tracking of diagnoses and symptoms in order to determine when to change treatment is a hallmark of the process of care elements. Measurement-based stepped care. I just alluded to an example of measurement-based care. The stepped care component comes in when you identify, for example, lack of improvement in symptomology and need to step up treatment. self-management support, linkages with community and social services, and systematic quality improvement efforts. The elements in this table marked with asterisks are those that we identified as being perhaps most feasible for smaller, lower resource primary care practice settings. Next slide, please. So as promised, here is panel B with the structural elements of integrated care. And these are just what they sound like. They're the structures that need to be in place in order to implement those core process of care components, including a multidisciplinary care team, clinical information systems, which really underpin much of the work that is done in effective integrated care models, including a population-based patient registry, shared electronic health records, inpatient and emergency department utilization data, and quality improvement data, which might include a mix of those other data sources, but which is systematically tracking key quality metrics, ideally, that are known to be associated with improved health outcomes. A patient-centered care plan for every patient is another key structural element. Decision support protocols to guideline concordant care, and financing mechanisms. And again, the asterisks here are those elements, those structural elements that the evidence suggests are feasible in smaller single or dual physician potentially or lower resource settings. Next slide. So I apologize, we're still missing Gail. It looks like she might have had a brilliant sort of accumulating thought at the end of that section, which was meant to be where we transition to the section that I had planned to present, but we can turn to her and question and answer for any insights that I missed. I'm gonna spend the rest of our presentation time focusing on policies to support integrated care. And I've organized my thoughts here around three questions. What have we tried? What have we learned? And what's next? In terms of what we've tried, most of the policy action to date around integrated care has focused on financing mechanisms. And that's because a key barrier to scale up of integrated care has been the historic lack of insurance reimbursement mechanisms for those key elements that we just discussed on the prior two slides, both process of care and structural. For example, we've not historically had billing mechanisms for care management. I'm going to highlight three strategies, and particularly the financing policy strategies within these models: CMS behavioral health integration billing codes, primary care medical home or PCMH reimbursement strategies, and accountable care organizations or ACOs. The CMS behavioral health integration billing codes are per member per month billing codes that were introduced in 2017. They're billable in Medicare, and some commercial payers and state Medicaid plans have also adopted the codes. There are 4 of these codes that can be billed by general medical providers, and 3 of the 4 are for care management and care coordination services specifically delivered within a collaborative care model. The 4th code can be billed for care management services, behavioral health care management services, more generally, delivered outside of collaborative care in any type of integrated care model. There's one study that looked at uptake of these behavioral health integration billing codes in 2017 and 2018. And that study found very low uptake, only 0.1% of Medicare beneficiaries with a mental health or substance use diagnosis had a behavioral health integration billing code, indicating that they got one of these integration services. Another interesting finding from this study was among that 0.1% of Medicare beneficiaries who had one of these integration codes, 75% of the codes were for the general behavioral health integration service as opposed to a collaborative care service. And there's been some follow-up qualitative work to try to understand why uptake around these codes has been low. And one of the key explanations that I think parallels that finding that I just alluded to about the general code versus the collaborative care code is that many practices lack the structural elements needed to bill for these codes, particularly the collaborative care codes, which require that you have in place many of those structural elements that we showed on the prior slide, including on the staffing side, a consulting psychiatrist and a behavioral health care manager. Primary care medical homes, in contrast to the behavioral health integration billing codes introduced by CMS, are not explicitly focused on behavioral health integration. Primary care medical homes are focused on improving primary care writ large. It's a model based, like collaborative care, on Wagner's chronic care model, and has been used, is increasingly used over time to integrate behavioral health into primary care. On the financing policy side, what we've tried so far has looked quite similar to the CMS behavioral health integration billing codes. Per member, per month reimbursement, relatively modest in size, ranging from $20 to $200 per beneficiary per month payments that are designed to be used to cover care management or other previously non-billable process of care services. And the two sort of primary models where we've seen this attempted are federal demonstration programs, the Comprehensive Primary Care Program and the Multi-Payer Advanced Primary Care Demonstration Program. Both used this type of per member per month payment to finance process of care elements, again, not specifically targeting behavioral health, but that could be used for behavioral health. And what we saw was that these financing mechanisms did not lead to high uptake of evidence-based behavioral health integration practices. Finally, accountable care organizations like primary care medical homes are not specifically focused on behavioral health integration, but they have the potential to incentivize behavioral health integration through shared savings and potentially losses in two-sided risk arrangements that are tied to achievement of quality of care and healthcare spending targets. Despite the proliferation of accountable care organizations in the US, the available evidence shows that ACOs have had very little effect on care for people with mental illness or substance use disorders. The available studies show some small, but likely not clinically meaningful increases in utilization, or in other studies, no effects at all. The common explanations for the potentially unrealized opportunity of ACOs and behavioral health integration has to do with two factors. One is that a now pretty large body of studies clearly shows that behavioral health specialists are often excluded from ACO networks. And there has been a misalignment between ACO payment incentives and behavioral health performance metrics, by which I mean that other performance metrics for general medical conditions have been emphasized. Next slide, please. So what have we learned? I'll highlight 3 points here. First, Our experience with the initiatives that I discussed on the last slide suggests a need for multi-payer financing arrangements that support both process of care and structural elements of integrated care models. The behavioral health integration billing codes and the per member per month payments designed to prompt adoption of behavioral health integration in primary care medical homes have focused on process of care elements. But as I alluded to a moment ago, what we've learned in qualitative research is that the frontline implementers tell us we can't implement those process of care elements because we don't have the structural elements in place, and we can't afford to put the structural elements in place. A second key lesson learned is the need for accountability of the health of the whole person. We have historically held primary care physicians responsible for general medical conditions and behavioral health specialists responsible for behavioral health conditions. And that does not incentivize truly meaningful collaboration and care integration around improving the health of the whole person. Accountable care organizations, by virtue of their incentives around improving potentially whole person health, could be part of the answer here if we overcome some of those barriers that I mentioned a moment ago, like the failure to appropriately align payment incentives with behavioral health performance metrics. We've also identified some policy barriers to integration that still exist out there in the world, and I will highlight a couple of them here. Same-day billing limits are a problem that have been identified in Medicaid, where multiple state Medicaid programs prohibit clinicians from billing for a general medical service and a behavioral health service for the same person on the same day, which is antithetical to integrated care. The 2016 21st Century Cures Act clarified that federal law does not prohibit this same-day billing. The federal Medicaid statute had previously been commonly misinterpreted as including this prohibition, and that prohibition then made its way into being mirrored in state Medicaid policies. Despite this federal clarification, however, we know that this same-day billing limit still exists in multiple states. We unfortunately don't have an up-to-date count of states that have this policy barrier in place. The most recent comprehensive legal mapping that was done was performed in 2015, so the year prior to that federal clarification. And at that point, 24 state Medicaid programs prohibited some or all settings and provider types from same-day billing. Behavioral health carve-outs are a major policy issue in the behavioral health policy dialogue right now, and they are frequently cited as a barrier to integrated care, though evidence, as I'll tell you more about in a moment, is pretty limited. A carve-out means that behavioral health benefits are administered by a separate organization than general medical benefits. And providers and some insurers have cited this separation of benefit management as a barrier to care integration. However, the evidence, as I said, is limited, and we don't at this point have strong evidence about whether carving benefits back in, integrating benefits, will in fact lead to meaningful improvements in behavioral health integration. There's one study by Zhang and colleagues that looked at carve-in of behavioral health benefits in the Illinois Medicaid program. And they found that carving in benefits resulted in a decrease in behavioral health costs without changing behavioral health utilization. And while important, those findings don't answer key questions about the degree to which that carve-in prompted care integration processes or improvements in quality of care or health outcomes for people with behavioral health conditions. There are also various condition-specific policy barriers out there. The ones that rise to the forefront in my mind are federal regulations around prescribing of the opioid agonists methadone and buprenorphine. In order to prescribe buprenorphine, primary care providers have to obtain a special waiver from the federal government, and methadone can't be prescribed in primary care at all. It can only be prescribed in specialty programs. Next slide, please. And finally, what's next with my last couple of minutes of speaking time here? So I've spent the last 12 minutes or so talking about financing policies and how we might improve financing policies to support evidence-based integrated care. But ultimately, financing policies are likely necessary, but probably not, in my mind, sufficient to truly prompting adoption of complex, effective, integrated care models. And two areas where I see a strong need for additional policy activity to support care integration are the behavioral health workforce and social determinants of health. Behavioral health workforce gaps are a frequently cited barrier to implementation of integrated care by general medical clinicians. They say we want to implement an integrated care model, but we don't have enough behavioral health providers in our area to collaborate with. There are various policy options that could be considered to address this issue, ranging from traditional healthcare workforce policies like loan repayment programs to telemedicine. Better reimbursement for behavioral health services delivered via telemedicine has the potential to ease some of these gaps, particularly when they're geography specific. We are, of course, in a moment around COVID-19 where there's a very rapidly evolving landscape with telemedicine. And so hopefully there will be some lessons learned that can be applied moving forward. Ultimately, to really and truly meaningfully address the behavioral health workforce, I will echo what mental health economists have been saying for decades, which is that we need to reimburse behavioral health services at a high enough rate that allows behavioral health clinicians to be paid at a rate high enough to incentivize them to choose often challenging behavioral health careers. And finally, the social determinants of health, poverty, unemployment, housing instability, criminal justice involvement, these determinants are overrepresented among people with mental health and substance use, and they contribute to many of the barriers to care and poor health outcomes experienced by these groups. Again, there's a range of policy options to consider here. Large-scale social safety net policies that target people, including but not limited to those with mental illness and substance use, are certainly relevant. I would also highlight the need to think, given the focus on integrated care in this webinar, about models that integrate not only general medical and behavioral health care, but also social services. Accountable care organizations and their recent extension into the community, accountable health communities, may offer some lessons about the types of policies that can incentivize that type of three-way integration. Thank you very much. I'll stop there.
Thank you, Beth. And thank you to Gail. Thank you, Beth, particularly for jumping in when we had a technical problem with Gail. In the midst of a thunderstorm, we lost our co-chair to the thunderstorm, who's back, I understand. This is the point in the program when there's thunderous applause. Unfortunately, you can't hear that thunderous applause, and neither can any of us because we're disconnected from those hundreds of people streaming this particular presentation. We're going to turn our attention now to the part of the program for panelist comment, followed by panelist questions, and then I'm hoping that we have time for some questions to answer from participants who are sending in their questions stimulated by this really outstanding paper. As the moderator, I'm going to take the chair's prerogative to lead off with a comment. And my comment is going to be addressed first to the process, the collaborative process that led to this paper's development, because I think it's an important part of what we're trying to do with the forum, which is to draw upon the talents of forum members and our larger community. 3 entities collaborated to make this paper possible. The first came from a commissioning of the paper by the Think Bigger, Do Good policy paper process, which is sponsored by 4 foundations, Scattergood, PEGS, Lee, and Tower, who are also the newest members of the forum, I should add. I've been editing those policy papers with Connie Gartner, and Colleen Berry is a member of our editorial advisory group, and she first initiated the idea of having a paper on this topic right around the time that the forum was considering making it a focus of our first workshop. So that's the second collaborative part. That's the National Academy of Sciences and our forum. And they agreed that if we had a commissioned paper that we could use it as the foundation for what then was a one-day workshop and now is a series of webinars. And I think that this paper does a very good job of laying a foundation for the subsequent conversations. And then third, I should say that our policy series at the Think Bigger, Do Good activity is connected to psychiatric services. Lisa Dixon agreed to have these papers peer-reviewed and published in the journal. And I believe that either today or tomorrow, this paper is available both as a freestanding white paper from the Think Bigger, Do Good process. It's also on their website, and it's been published officially in psychiatric services in advance. So we've illustrated the kind of collaboration we can do within the behavioral health field. It's now incumbent on us to do a better job in integrating between behavioral health and general medical care. But lest you think that this is a new topic, I just wanted to add that 40 years ago, I wrote a background paper for an Institute of Medicine conference on integrating health and mental health care. That paper 40 years ago focused on the historic separation between these two larger health and social welfare enterprises and raised questions about why the ongoing separation was so challenging to overcome. Now, some has changed. At that conference, the focus was on diagnosis and referral from general medicine to specialty care, because no one at that time thought that general medicine would really pay much attention to implementing evidence-based practices. We've learned over the 40 years since that there are models. You, Beth, and Gail have presented some of them to us, and that gives me reason to be optimistic, even though this particular topic remains on our stage and commanding our attention 40 years later. So let's go to the panel. The panelists will each in turn make some comments. Then it will come back to me and I will start off a question and each of the panelists will ask a question. And we go first to Ruth Shim, followed by Colleen Berry, who's back after the thunderstorm, and Deidre Roach. Ruth?
Thank you, Howard, and thank you, Gail and Beth, for really just an excellent presentation about how we can start to move forward thinking about wide-scale integration. I was struck most, I think, Beth, by your final statements and comments about social determinants of health and why that's so important to be thinking about separately and independently as we think about how we're going to effectively integrate, that we have to integrate, we have to figure out how to integrate social determinants of health and social determinants of mental health into the work that we do in primary care. And I feel that we are making a lot of traction in that space. I think that in the last several years, there's been movement to incorporate more work around social determinants of health and bringing all of that into the world of integrated behavioral health care. So So I believe we're making progress on that, and I just wanted to highlight that and elevate that as my thought and reaction on hearing the panel.
I'll take it up from there, and I couldn't agree more with Ruth's comments. I think I'm primed this week to think about historical legacies and how they operate to slow progress in often profound ways. We see that around us right now, but I think we also see this in the long tail of fragmentation and institutional separation in the context of healthcare and mental health and addiction care. And it really is profound. You know, Beth, that was not a success story that you were describing to us. And when we think about the arc that Howard alluded to of his career and watching these issues evolve, it's discouraging, frankly. And we need to figure out how to move the ball, but we need to, as you, Beth and Gail, have so nicely done, diagnose the problems first. And for me, often when I think about how mental health and addiction issues are handled, are treated, are financed differently from the rest of the healthcare sector, to me, it comes back to economics, institutions, or stigma, or all three. And I think thinking hard about what we know about economics, and I worry a whole lot about adverse selection, I have to say, as playing a role here. And this didn't come out, although I know you guys think about it a lot, as much in our conversation thus far, but in particular at a moment where our healthcare systems are increasingly going to be under financial duress. There are going to be really strong incentives to save funds, and that means to go after and cherry pick the easiest patients to deal with. So in some sense, this crisis that we're in as a country is going to pose even more significant challenges to integration. And we can't underestimate, as Beth, you so nicely put, the slowness of institutions to move and to evolve. And of course, stigma is profound. We've made little progress in lowering stigma toward the individuals who we are trying so hard as a field to provide services to, that is individuals with mental illness and substance use disorders. So I'll leave it there and I think kick it over to Deirdre.
Simply like to again thank our speakers, for those very stimulating, thought-provoking presentations. To echo some of the principles that Colleen and that Ruth have pointed out, I couldn't agree more with your assessment that where we go from here will revolve heavily around a consideration of economics and stigma. Institutional policy. But what I might add to that is the importance of community participation going forward. I think that is a factor that has been largely overlooked in our planning of integrated care, and that could make a significant difference in what our progress will be going forward. And also to underscore, there is an important role for more research in these areas, and that my strong recommendation would be that those research efforts also be community-based. That is, use the community-based participatory model, because I think it's the people who are living with these conditions who have the greatest wisdom about the best approaches that we can use to resolve some of these structural issues going forward. And that's all that I would add.
Thanks, Deirdre. We'll come back to you to ask questions. So I'll lead off the questioning of the panel and ask, what do you think are the key qualitative ingredients of integrated care? What we might call the soft signs, difficult to measure things like communication or teamwork. above and beyond the process and structural measures that you so nicely reviewed in your presentation. I don't know whether that's a Gail question. Welcome back, Gail.
Yeah, thank you, Howard. I'll take that question. And thank you for moving forward despite my whole computer shutting down unexpectedly. Yeah, so I think that these qualitative or aspects of integrated care are really important, and they are hard to measure. So things like the belief of the primary care clinicians and other people in the practice about the importance of population health, the goal of improving whole person health, shared values around those things. What is the implementation climate like? Does the leadership support integrated care and evidence-based practices around collaborative care? And how do people feel the self-efficacy that they can deliver this care? So those things can be measured, but they are a little more challenging to measure.
Thanks, Gail. Did you have anything you wanted to add, Beth, or should we go to Ruth's question?
No, I think Gail hit the key points, so I'll leave it there.
Okay, great. Ruth?
Thank you. So my question actually builds a little bit on Howard's question. If thinking about qualitative ingredients, it also has us thinking about culture. And so I'm wondering what cultural shifts are needed to facilitate care integration, and how might we go about achieving those shifts?
So I'll take that one again. I think that, culture is really, really important. We talk about organizational culture. So what is the leadership thinking? What are all the different levels of clinicians and staff thinking in the organization? And what are the explicit and implicit incentives, formal and informal, that are contributing to that culture and climate? I think, again, this shift from the silos of physical health and mental health and towards shared responsibility to the whole person health. And I think the de-siloing of medical training, and that the organization needs to support that at whatever level you are, that it emphasizing that when new evidence-based practices come out, that they're important to learn. I also think financial incentives need to support that and will help move the cultural shifts towards integration.
Great, thanks, Gail. Colleen, you have a question?
Yeah, so I'd love to pick up on the theme of workforce. Both of you alluded to the importance of the workforce. What are the major barriers that the workforce itself poses to care integration, and how can we overcome it?
I'll take the lead on this one. So I think we've alluded to some of these points already, so I'll try to amplify them. When I think about this big picture, I think of it in two buckets. One is that we have behavioral health workforce shortage, and how do we overcome that shortage? And then the other bucket is, in the workforce we have some gaps and competencies, and how do we overcome those gaps? So I discussed briefly some of the strategies for overcoming workforce shortages. I think that there is real promise, and that this promise has been elevated potentially, or accelerated, as a result of the COVID-19 crisis, which has predominantly such negative effects, but I think that the potentially lasting effects on the expansion of telehealth are one that could have real benefit for these workforce shortage issues, in that, to the extent that those issues are geographic and sort of not universal, and you can work with someone who is, perhaps several hours away by car, telehealth can overcome that barrier. I would again just emphasize that I think a lot of what's driving this workforce shortage is the economics that you alluded to in your comments, Colleen, and we don't pay adequately for behavioral health services. And as a result, we don't have competitive financial packages, salaries for behavioral health clinicians. They're not adequate to incentivize people to join the field. So that's a key one. And then in my second bucket, I think I'll elevate a point Gail made around clinician training, where we need to make sure we have accreditation policies, education policies in place to make sure not only that general medical providers are getting some competencies in delivering mental health care and vice versa on the specialty mental health side, but also that we're training in team-based care and in the process of care elements that are so integral to integrated care, but are often fairly foreign to our medical trainees.
Beth, I would just maybe chime in to mention an issue I know you've thought a lot about, which is that telehealth only works to the extent that people have the technology they need to be able to use it. So the digital divide that we all are worried about so much right now is huge here too.
Absolutely, which is why some of the policy changes made in the disaster context, like allowing at least some services to be delivered by phone versus by computer, which doesn't totally solve the gap. Of course, some people have access issues around telephone too, but potentially if we can keep some of those policies in place, it could really help.
I also just wanted to mention, to add to Beth's point, that I think we should also be looking at mid-level providers. So nurse practitioners, physician's assistants who, can be able to prescribe medications and could really be helpful in primary care practices as parts of teams. And there are shortages of those as well for the mental health workforce.
Thanks for this back and forth. We're certainly learning a lot during the pandemic about telehealth care. And one of the things we've learned is that some behavioral health service users actually prefer the telephone to the video hookup. And so some of the digital divide can be overcome and be consistent with service user patient preferences. So that's a good thing. Deidre, do you have a question?
Yes. Thank you. One of the most troubling observations to me of our recent experience in integrating healthcare is that even when we successfully implement the key elements of collaborative care in real-world settings, we may not see the benefits on depression outcomes, as in the Diamond Initiative. Why do you think this is?
I can take the first go at this one, although I suspect Gail will have important contributions to add. This is the $1 million question in my mind. It troubles me, as you said, Deirdre, as sort of the crux of the issue, which is that, we've shown in rigorous trial after rigorous trial that collaborative care-based models can be effective in improving depression symptoms and remission, improving outcomes among people with substance use disorders. But when we implement in the real world, we see this voltage drop phenomenon, which is not unique to collaborative care or integrated care. We see it in the trial to real world translation context writ large, but it's a big problem here. And I think quintessential example of that is the Diamond Initiative that you alluded to. Diamond is a statewide initiative in Minnesota designed to implement collaborative care for depression. So depression care in the primary care setting. And this Diamond Initiative really did a lot of things right. A lot of the policy recommendations that I made a few minutes ago, Diamond did. It was a multi-payer initiative. It included payment designed to cover both process of care and structural elements. It included pretty intensive training for leaders, frontline providers, staff, included a care management tracking system to get over health IT barriers, consultation. It really sort of a intense, supported model. And the evaluation showed that while the STIMID initiative resulted in delivery of more depression care in the primary care setting, which is certainly a good thing, that's progress, there were no effects on patient outcomes in terms of improving depression symptoms or remission. And that finding is through a pretty rigorous, stepped, wedged, pragmatic trial. And so it's very discouraging. And so the why and the how do we overcome that is really the key question here. And I think it's one that the field is grappling with and that I don't totally have the answer. One potential answer is, well, there's sort of a secret sauce in clinical trials that is really hard to replicate in the real world, where you have a research team that's often pretty singularly focused on this one thing, implementation of collaborative care, where in the real world, of course, frontline providers' attention is focused on a bunch of other things. And perhaps we just can't replicate that secret sauce. That's a very discouraging answer, because how do we overcome that, right? But I think that there are also a lot of people thinking about what we need to do here is really figure out what are the key elements that are not being translated from the trial context to the real world context. And the one that the field, I think, has some consensus around, although it hasn't been borne out empirically, it hasn't been studied empirically, is the treatment intensification issue, which Gail raised earlier as just being really critical. And this idea that they couldn't really get at it in Diamond to know whether this was the problem, but there was sort of a suspicion among the implementers that what was often happening was that all the components were being implemented, but treatment intensification just wasn't being done to the degree that it was being done in trials. And so perhaps that is this sort of key, as yet untranslated ingredient, and that if we could figure out how to get treatment intensification in place in a really standardized and rigorous way, that might help overcome this barrier.
Thanks, Beth. Gail, do you want to add something here? I saw you nodding your head.
Yeah, I agree that I think treatment intensification is really important, and that you can, train primary care doctors relatively easily how to start an antidepressant, but it's really once people still have symptoms that I think that there are a lot of barriers. I also think just in general, speaking as a primary care physician, we know that we need to be really providing better mental health and substance use services in our practices. And at the same time, primary care practices are also under a lot of stress. There's a lot of financial stress, the stress of seeing more and more patients in a shorter period of time, stresses of electronic health records, et cetera. So perhaps telehealth could be a possible solution to some of our issues, our challenges in integration. But we know that primary care, it also is a relatively underpaid specialty, again, with its own challenges. So I'm hoping that one of the ways that we can really work on integrating behavioral health and primary care is as we try to improve primary care through these different models, some of which Beth spoke about, that we can also just make sure that we're incorporating the behavioral health priorities in those, for example, in the ACOs, where we make sure that of the priority conditions, it's not just hypertension and asthma and diabetes, but that depression is right up there, and that we can weave things in that way.
Thanks, Gail. Those are some good suggestions, and thank you for trying to unpack this very challenging question. It does occur to me that we sometimes forget that depression is a very heterogeneous phenomenon, and it can be extremely resistant to treatment sometimes. I think it's often forgotten how many no difference findings there were in medication clinical trials in the treatment of depression. So it's not always a slam dunk, even if you put in all these processes in place, that the active ingredients will actually be as efficacious as some studies have demonstrated. It's a great discussion. I'm going to take the last question before turning it over to audience participation. You know, for decades, we focused on carve-out arrangements for financing. And suddenly, reintegrating financing and carve-in arrangements has become the vogue. If it's such a great way to promote general and behavioral health integration, are there any downsides? I don't know, Beth, whether you want to start?
Sure. So I think there could be. I won't rehash it, but I think, as I said in the presentation, we also don't have at this point strong evidence around sort of carving in being a really good thing for behavioral health integration. It makes intuitive sense on many levels, but it hasn't at this point been empirically demonstrated. I think the concern in my mind is that a potential benefit of carve-outs is that they have expertise in specific specialty services, things like psychiatric rehabilitation, perhaps, or intensive outpatient care that may not have clear parallels on general medical side services. And experience managing those types of benefits is very important for particularly high need subsets of people with behavioral health conditions, like those with serious mental illness, who both Gail and I spend a lot of time thinking about how to help. Gail, you may have things to add.
Yeah, I very much agree. And I think that, you know, a well-run carve-in could be great. I think there's concern about negative incentives, and when budgets need to be cut and services cut, you know, I worry, and others worry, that the behavioral health services will be, you know, of the first to go. So I agree with Beth.
Carve-out arrangements were designed initially for two purposes. One was to have the management of care overseen by people who had specialized appreciation for the needs of people with behavioral health problems. And two, maybe most importantly, to protect a share of premium so that it would be allocated to behavioral health and not taken away. Almost 50 years ago, our friend and colleague Steve Sharfstein wrote a paper about how to get into the mainstream of healthcare financing without drowning. And I think that what's implied by that question is revealed today in the debate between carving out and carving in. I want to thank our panelists for their comments and for their questions, our authors for responding to our questions. Now we're going to turn towards the audience participation. We have 15 minutes left, and maybe even a few more beyond that. Turn it over to Lori Gregg, who's been fielding and filtering these questions, and she will restate them and see how either our authors or panelists want to respond to them. Lori?
Thanks so much, Howard. The first question from a webinar participant asked if the panelists could please comment on the role of training primary care providers regarding stigmatization of people with mental health and substance use disorders. Specifically, the participant notes, I hear PC providers say, quote, "We don't have those people in our practice," end quote, "We don't want to become a place where those people come," end quote. The latter is particularly relevant in advocating for primary care physicians to become waivered for buprenorphine.
Well, there's the first challenging question. Who wants to try to field that?
I can just say, I mean, comments like that are just, they're very concerning and upsetting. I think that, you know, we don't want to be enrolling those individuals into medical school or into, you know, internal medicine or family practice residencies for sure. And I think that we need, much better training, maybe screening starting when people apply to medical school, and then much better training in medical school and afterwards to ensure that this has to change. I think that, once people go into their practices and healthcare organizations, the organizational culture and climate cannot tolerate, anything like this anymore. I think the time has come. I think that we need to be really recognizing consumers with mental illness and substance use as, a disparities population that, deserves all the same, interventions to break down stigma as other minority and disabled populations have had, over the years. So we need to redouble our efforts in this and that.
Can I chime in and just ask
Please.
Beth to comment? Beth just recently led a national study of primary care physicians that was published. And I think it would be great, Beth, if you could share sort of at a high level what you found, but also sort of your view on what the approaches might be to try to address this issue.
Yeah, absolutely. So I think that this is central. Thank you so much for raising this issue of stigma. And I think that incorporating anti-stigma training for PCPs is absolutely critical. It should be a core component of both sort of initial, medical school or nursing school training, as well as continuing education. We have seen this work in terms of implicit bias training around race. There are models out there. We need to build out those models and and figure out which ones are most effective for mental health and substance use stigma specifically. I think there's more work to be done there. Colleen is involved in some such work. In terms of the study Colleen was referencing, it was related to opioid use disorder. In particular, we did a national survey of primary care physicians in the United States and gauged their attitudes about people with opioid use disorder and about medications to treat opioid use disorder. And what we found, which I don't think is counterintuitive, although it may be to some audiences, is that primary care providers both endorse the medical model of opioid use disorder. They say it's a chronic disease like diabetes. People can get well with successful treatment. They believe that, right? There's not a belief that I think is very prevalent among the general population that substance use disorders in general are a moral failing and sort of the person's own fault. But at the same time as endorsing that medical model, primary care physicians hold other quite stigmatizing attitudes toward people with opioid use disorder. They are very unwilling to have a person with opioid use disorder, even a person who is on stable treatment with guideline concordant medication, as a neighbor or to marry into their family. They don't want a clinic that provides buprenorphine or methadone in the neighborhood where they live. And so these stigmatizing attitudes exist side by side with the medical model. And I think too often with clinician audiences in particular, we really focus on endorsing this medical model. It's a disease, right? If as long as we all buy into that, there's no stigma. And that is absolutely not true. And so I think this point about needing to address this head on with anti-bias training techniques is absolutely key.
I would just like to add to what was said. I think I really appreciate the audience member who asked this question, because I think it's so critical. And I think it's so critical right now in this time and in this moment, because, we talk about stigma against people with serious mental illness and with substance use disorders, but really it goes even far beyond stigma to discrimination. And the behaviors that result from discrimination. And so, it is systemic and structural discrimination of people with serious mental illness and substance use disorders. And I really appreciate Gail's comment about we have to do a better job of evaluating the workforce and making sure that the people that we bring into the profession don't harbor discriminatory beliefs towards people with serious mental illness and substance use disorders. And to Beth's point, I think it's really interesting that these are negative opinions about opioid use disorders, which are the most positively perceived substance use disorders that exist. So if we move even beyond opioid use disorders to other substance use disorders like alcohol use disorders and cocaine, methamphetamine, heroin, the perceived destruction and beliefs about the moral failings of people with these conditions, with these medical conditions, and the social distance that comes from people not wanting to be in presence with these people becomes a massive issue that we have to think about how we're going to tackle.
And I would
please go ahead, Deidre.
just very briefly that anti-bias training needs to begin at a very early stage in the educational careers of providers. I would suggest, well before they start medical school, into graduate school or even high school, because these attitudes become ingrained, as we know, at a very early age, and they're hard to reverse once they're ingrained.
Just one final point. This was clearly a very rich conversation around this comment. I won't belabor it, but I think that it is really critical when we think about this topic to recognize that the anti-bias training and anti-stigma work alone is likely not enough. It needs to be paired with policy and system level changes and deeper training level changes that empower clinicians to work with people with behavioral health disorders in a way that is effective for everybody, right? That isn't forcing 5-minute visits with someone who has complex needs, that isn't, trying to destigmatize working with people with opioid use disorder among hospital staff that don't have an addiction consult service and have sort of nowhere to turn and are constantly frustrated by their lack of ability to help people. You need sort of all of these things packaged together, and the anti-stigma work is going to be most effective if it's part of that package.
I just wanted to thank the questioner for asking this challenging question and for the varied responses from our panel. Sorry about the technical problem. Laura, you have the next question for us?
The next question, there are a number of questions from webinar participants about CMS behavioral health billing codes. This participant asks if the panelists could speak further to the uptake issue for CMS behavioral health integrated billing codes. They wonder if states couldn't use 1115 waiver dollars to promote adoption and provide technical assistance to primary care practices. They ask if there are any states doing that you're aware of.
Sounds like a Beth question.
Yeah, it's a great question. It does seem like a potential use for 1115 waiver dollars. I don't know of any states that are doing that, although that doesn't mean that there aren't any out there. And I do think, maybe just to amplify the underlying point there, that there is definitely a role for technical assistance around use of these codes and support in helping to get some of the structures in place to help practices build these codes. But I will say that one of the key barriers identified in the qualitative research around uptake was that for the collaborative care codes in particular, you need some of those structural elements, in particular the staffing elements, a behavioral health care manager and a consulting psychiatrist on staff. And so technical assistance alone isn't going to overcome that one.
Yeah, the AIMS Center at the University of Washington has provided technical assistance both on the conduct of collaborative care, but also on some of these policy issues. And I'm pretty sure that some of the professional organizations like the American Psychiatric Association has done similar things.
Yeah, AIMS has a great toolkit online.
Yeah.
There's a cheat sheet and a bunch of resources.
Right, that's the AIMS Center, AIMS Center at the University of Washington. Any other panelists want to elaborate on this one? That was good, concrete suggestion. Lori, another question for us?
Great, thank you. The next participant asks, there are various ways of integrating behavioral health and physical health, co-location, integration of behavioral health into primary care providers, integration of primary care into behavioral health. Is there any evidence or indication whether any of these approaches is more effective than the others.
Thanks, Lori. Any of the panelists want to take it up? It seems like it gets to the core issue that Gail was reviewing in her part of the paper.
Right. So there's a lot more evidence of the collaborative care model where integrating behavioral health into primary care has been shown in many randomized trials to be effective for not only depression, but anxiety and other, like depression and diabetes together, for example. I think a lot of my work and my work with Beth focuses actually on trying to integrate physical health care into behavioral specialty mental health. The collaborative care model for primary care, behavioral health and primary care, we have lots of evidence that works, right? For mental health conditions and also for some comorbid mental and physical health conditions together. We have much less evidence that bringing physical health to behavioral health or especially mental health settings for people with serious mental illness is effective. That's something Beth and I work together on, and we are going to be having some results coming out soon on a study that's looking at that. But in general, I think we need a lot more work in that area because we don't even have as much of the basic efficacy studies yet.
I know that that's going to be a product, an exciting new product from the Alacrity Center. And perhaps that form of integration will be the subject for the forum to consider for a subsequent workshop. I'm looking at our timing here, Lori. You're our main timekeeper. Do you have another question or shall we throw it over to the closers?
I think the closers should take over. Thank you, Howard.
All right. Thanks a lot, Lori. Thanks to the audience for their insightful questions. And the final thank you comes from Ruth and Deidre, and I'll just sign off and thank everyone.
Yeah, I actually thought, Deirdre, it was you. But are you able to unmute? But I just definitely wanted to have us thank the speakers, the panelists, the attendees. This was such a wonderful discussion and opportunities for learning. And I'll turn it over to Deidre.
Alrighty, I apologize. I thought I was unmuted. But again, to echo thanks to our speakers, Drs. McGinty and Dalmet. Those presentations were very thought-provoking and stimulating. We'd also like to thank our panelists, Drs. Colleen Berry, Howard Goldman, Ruth Shim, and the entire workshop planning committee, the National Academies of Sciences staff leads, Laureen Gregg, Caitlin Freeman, and Anicia Wilkes, and the entire team at NAS. And a special thanks to our audience for joining us today. You are a very diverse, interdisciplinary group, and we know that you are indeed the key to realizing the changes that we're seeking. We sincerely, there will be a link to the recording of today's webinar available on the NAS website, is shown here. And closing, we sincerely hope that you'll join us again for future webinars in this series coming up on July 29th and August 26th. Links to register for these webinars are also available on the NAS website as shown here. So my final word is, although we couldn't be together physically today, we could still feel the energy of a committed community during this virtual gathering. As we speak, we believe that energy is transforming healthcare in the US such that in the foreseeable future, it will consistently reflect the reality that optimal physical health is only possible when there is optimal mental health and vice versa. And it's in that spirit of total well-being that we wish you safety, vibrant health, and peace.